Hi, everybody. We're just going to wait maybe one more minute. We have a lot of registrants for this conference, and so I want to give people a chance to get in, get the link opened up. So I'll just wait 1 minute. People just joining. I'm just waiting another minute until we get started. Let people join. Okay, I'm going to go ahead and get started. We have some housekeeping things to take care of first, so it'll give people a few minutes to join. Welcome, everybody. My name is Susan Buchanan. I direct the Great Lakes Center for Reproductive and Children's Environmental Health. And this center at UIC is the EPA ATSDR funded Pediatric Environmental Health Specialty Unit for EPA Region 5. So I know that's a big a lot of words in there, but EPA and ATSDR fund centers around the country that focus on reproductive and children's environmental health. And the center here for Region 5 in the Midwest is the Great Lakes Center. So I'm really excited to hear our presenter and our panelists today. Let me go over just a few housekeeping items first. Please feel free to put your questions in the chat. So everybody is going to be muted. And the chat is not going to be an open chat. The chat goes to our coordinator, Deviante Porter-Anduto, and she will receive your questions and then track them for our Q&A session. So feel free to put your questions in your chat. They will go to her. And then Deviante has also posted our agenda. She's going to put some relevant resources in the chat, so keep an eye on that. And then most importantly, for those of you who are taking this or attending for CME credits, there will be a link to the Qualtrics survey entered into the chat toward the end so that you can fill out that survey for your CME credits. And for the residents, if you noticed, we said that the first 50 residents to register would get a gift card. If you registered as a resident, we will contact you. And be sure that when you're logging into this, if you have logged in here with a different name than what you registered, then we're not going to be able to make that connection. So if you logged in with a different name, you might want to leave and come back using the name that you registered as a resident so you can get your gift card. So the last thing I'm going to talk about with housekeeping is that we are recording this presentation, this conference, and it will be available for 30 days afterwards. And so that will be made available. Deviante, is that going to be on CVent or our website? Sorry, I didn't check about that. Do you know? You're on mute.
Sorry, we're going to follow up and give everyone a link to the recording.
Oh, by email?
Yes.
Okay, great. Sorry, I hadn't clarified that. So we will have the recording available for people who want to share it with others for if you want to get CME credits or just share it. So let me just check the chat really quickly to make sure that there's nothing I need to address. Looks good. And I'll go to my second slide. Here we go. So because this is funded by EPA and ATSDR via the American Academy of Pediatrics, there is a disclaimer and an acknowledgement slide here that is required. I am also going to read this disclaimer that all speakers and committee members who are speaking today have submitted a full disclosure of faculty financial interest or relationships to us. They have indicated they do not have a financial interest or any other relationship with any manufacturer or commercial product which may be discussed at this conference. So just a quick look at the agenda. Most of you probably saw this when you registered, but here's our agenda today. We're going to start off with our keynote, climate change and pregnancy outcomes, a call to action. Then we will go to our panel with our three panelists, attorney Eve Gartner, and then doctors Gary Loy and Allison Cowett. So Marie, do you want to, I'm going to stop sharing and you want to share your slides while I introduce you. I'm really happy to introduce Dr. Marie Cabilla. She has been an attending physician and practicing OBGYN at Advocate Illinois Masonic Hospital since 2008. She completed her OBGYN residency at University of Illinois Chicago after graduating from University of Puerto Rico School of Medicine. She's director of the OBGYN residency family planning curriculum and director of the OBGYN resident clinic there at Advocate Illinois Masonic. She's a member of our Great Lakes Center for Reproductive and Children's Environmental Health at the University of Illinois Chicago, the sponsor of this event. Now, Marie, are you able to share and unmute yourself? All right, great. Yeah, that looks a little different from our Zoom, but there you go. And go, if you do bottom right, you'll get your full screen. Bottom right, see that big screen that right there down at the bar? Do you see my pointer?
Yeah, I believe you just need to start your slideshow. That's all.
There you go.
Okay, there we go. I think
Thanks,
that's
Marie.
great. Wonderful. Sorry. So hi, thank you so much for inviting me to speak. I'm Marie Cabilla. I'm currently working for Advocate Aurora, and I just wanted to mention, because it's kind of part of the story that I'll tell, that I'm originally from Puerto Rico, but I've been in Chicago now for about 20 years. So I'm a practicing OB-GYN. I kind of have a side gig being active in climate action efforts in my community here in Evanston, Illinois, mostly in my kids' school district. And while I was at UIC, I met Dr. Gary Loy, MFM, who, like many others, I consider him my mentor, and I'm so grateful to him for introducing me to the world of environmental health. And I certainly want to honor the fact that he made some significant contributions to this talk. So let's see, let me move this forward. So the only relationship to disclose is that I'm a physician champion for Region 5 PESO, and for Gary Loy, he's participated in the web development of CMEs that have been sponsored by UIC and the EPA, and is the obstetric advisor to the Region 5 PESO. So what I'm hoping to cover today is to talk about the adverse effects of heat-related illness and particulate matter on general health, but most specifically in obstetric outcomes, and learn how to advise patients on how to avoid these exposures, specifically heat and particulate matter, and hopefully talk about how to integrate climate advocacy into clinical practice. So what's up with the 10 years? I was already involved in environmental efforts when about 4 years ago, my then 8-year-old daughter told me one day after school that she'd heard at school that the world was going to end in 10 years. And I realized that what had happened was the third graders version of the telephone game, where they'd heard about the IPCC panel talking about we have 10 years at that point in order to limit global warming to 1.5 degrees centigrades, and therefore avoid the most catastrophic events, the most catastrophic effects to human health. And of course, it broke my heart, and it really kind of crystallized what intergenerational inequity looked like in front of me, because I realized that as adults, a lot of us were walking around like we have all the time in the world to solve this. Whereas for some in the younger generation, they were really feeling that the world was a ticking time bomb. And so I realized at that time that I couldn't sit around and have my kids watch me not at least try and do a little bit toward this big situation crisis that we're facing. So the good news is that we have a choice. And as I mentioned before, ideally we want to keep global warming to no more than 1.5 degrees centigrade. Currently, we have increased 1.1 degrees centigrade from pre-industrial times. In the map here by NOAA, you can see on the left the changes from the beginning of last century to the end of the next century if we do a business as usual scenario on the right versus if we do a rapid emission reduction on the left. And I'm sure it's not surprise to anybody here that the trend has been, accelerating. The 7 last years have been the warmest on record, and July 2021 was the warmest month that humanity has ever recorded. And so if you need to kind of visualize what that significant increase would be like, I know not all of us are in Chicago, but if you visualize what our current record-breaking day of heat in Chicago is, under the continued emission increases, that record-breaking heat day would be 10 to 15 degrees higher by the end of the century. So that's a lot. So there's lots of conversation about this in the public health arena. And a lot of the information for this talk comes from the U.S. Global Change Research Program, Climate and Health Assessment, which actually was called upon by President Obama's 2013 Climate Action Plan. Hopefully you heard that when the UN had its climate change conference in Glasgow last November, the WHO held a conference specifically on health and the climate crisis, calling on governments and private businesses to drive a green and healthy recovery from COVID. In the public health world as well, in 2019, the AMA endorsed the term climate crisis to better convey the urgency of the situation. In 2021, ahead of Glasgow, 200 health journals came together for an open letter where they called on governments to effect climate action in order to avoid catastrophic harm to health from climate change. More pertaining to the gynae world, ACOG published a position statement in 2016 on climate change in women's health, and stated that climate change broadens health gender disparities by decreasing access to education as well as relinquishing reproductive control. Yet, with all this talk in the professional and public health arena, a lot of us are really unsure as to how to kind of address this in our day-to-day office life, right? So the good news is that if you poll the American public, clearly the majority of the population understands that global warming is happening and that it is related to human activity. And the percentage of people who are very concerned is, pretty rapidly increasing. So because climate change is inseparable from human health, I argue that it is squarely in our lane as providers. And I know what you're thinking, there's no time and I don't have all the answers. The good news is there are a lot of resources that I'll review a little bit later that allow us to bring some of this into the office while still remaining efficient. And as far as not knowing all the answers, I hope that most of you are with me in realizing that through our training, we really have become experts at digesting large volumes of information and being able to distill it in a way that's understandable. And so I think certainly it takes some preparation. That's a lot of that is already kind of digested for you, but a lot of what it takes is kind of the interest and the enthusiasm to know where to find the answer if you don't know it. I'm sure this is not news to any of you here, but I think it's a good idea to just take a second to review how to explain global warming, or rather climate change, in a nutshell. And basically we're creating greenhouse gas emissions that create a blanket over the earth, and that is trapping heat, and that heat will increase the water temperature, and that in turn will increase precipitation and extreme weather events. So this is a CDC infographic on the impacts of climate change on human health. And don't worry, before your eyes glaze over, we're really going to focus specifically on air pollution and extreme heat. But suffice it to say that certainly the effects are much more far-reaching than that, and it includes changes in the vector ecology, which is why we're seeing Lyme disease in places where we weren't seeing it before, increased cases for foodborne illness, diarrheal illness, as well as nutrition, food insecurity, not just from lack of food from droughts, for example, but also there is decreasing nutritional content in the foods related to climate change. So what are the effects of extreme heat on health? I think the take-home point here is that heat, we typically see it as something annoying, but it's not just a nuisance. It's actually very, very dangerous. And as a matter of fact, it actually drives a lot more deaths than all other weather hazards combined. And those deaths typically stem from stroke, cardiovascular disease, respiratory illness, and I said them all. The implications of heat vary depending on the location and the timing. So an example of that is that 95 degrees in Vermont in May is not the same as 95 degrees in Texas in August. And that has to do both with the acclimatization of the body, as well as the resources and the infrastructure that the place has to deal with extreme heat, right? How does heat stress come about? Essentially, when we're exposed to heat, our blood will flow to our extremities and through vasodilation in order to transfer that heat out as sweat. And then when we sweat, we're going to decrease that volume, which can, of course, lead to acute kidney injury. And in turn, it'll increase cardiac contractility. And the issue there, of course, is that if we're demanding more oxygen than the supply that we have, that is what can lead to that infarction. We may remember that the physiologic changes in pregnancy, where a woman already has increased cardiac output and vasodilation, make it so that our ability to thermoregulate is already strained. And so that's why it's easier for a pregnant person to have heat stroke. So if you haven't watched this documentary, I really recommend it. It's Cooked: Survival by Zip Code. And it talks about heat as yet another example of health inequities, of course. So the documentary tells the story of the 1995 Chicago heat wave, which killed 739 people in the city of Chicago. And if you're thinking that this mass grave is in some place far, far away, this mass grave is actually in the nearby suburb of Homewood, Illinois. And it's where a lot of the bodies were laid to rest, when family members did not identify them. So clearly we know that the most vulnerable people are the elderly, patients with comorbidities, mental health issues, certain medications, and of course always outdoor workers. Sociologists actually studied the whole heat wave and specifically identified that risk factors really honed in on the lack of social connectivity, as well as living in an urban heat island, which of course is an area that does not have as much green canopy and can be up to 15 degrees Fahrenheit higher than other areas with better canopy coverage. And to me, one of the saddest things about this heat wave situation is that the same zip codes that were most affected by this heat wave in 1995, those correspond very well to the heat wave, to the zip codes that were most affected by COVID more recently. So it's been 30 years and it seems like we really haven't done a lot in terms of limiting those health inequities. So healthcare delivery, this can certainly be its own presentation, but I like to include it in part because it's kind of my story coming from Puerto Rico. But of course, it's part of all of our stories because we all participate in healthcare delivery. the healthcare sector is responsible for almost 10%, about 8.5% of all greenhouse gases produced in the US. So there's a lot of room for climate action in the healthcare sector. And an example that I really like is desflurane, which is an anesthetic gas that has 20 times the global warming potential than other alternative anesthetic gases. And a big success story that I have from Advocate Aurora is that from 2017 to 2020, we were able to decrease our greenhouse gas emissions related to anesthetic gases by 75%. By just switching from desflurane. In the process, we saved $1.6 million and the equivalent of driving 21 million miles. So that's a lot. So just like healthcare delivery drives climate change goes right back and affects healthcare delivery, of course. And this picture on the left is a picture from 2017 in Puerto Rico, and it's surgeons operating in a field that was lit by their cell phone lights. So after Hurricane Maria, 2 weeks later, only 9 out of 68 hospitals had power. And on the right, you can see a memorial that commemorated the 4,654 deaths that the New England Medical Journal uncovered in their research. This was actually 70 times more than the official death count that was provided by the government. And I think that when you look at this picture, it's easy for us to kind of visualize why a lot of deaths may be attributed to, heart failure or hemorrhage. But when you look at the situation surrounding, you can see that these deaths, a lot of them were caused by the suboptimal care due to the extreme weather event. So long after when almost everybody had forgotten that the hurricane had happened, aside from the people that were still on the island, of course, I remember being here in Chicago and hearing about the lactated bringers shortage and drug supply shortages that were caused by facilities still being closed in the island. So I think, after COVID, we don't need a lot of reminder, but climate change is yet another reminder of our interconnectedness. As I mentioned before, ACOG has spoken about the widening gender disparities related to climate change. And I'm acknowledging I'm going to be using the gendered language that comes from the original document, and ACOG and all of us are working on finding more inclusive language. But they note specifically in this committee opinion that women are responsible more often for obtaining food and water. And of course, they're less likely to have resources and decision-making power. And in the rural areas, that can lead to less access to education. I would say that if we're in a more urban setting, like most of us in our context, it can certainly lead to decreased access to contraceptive and abortion care. And the lack of transportation and the having to shelter in place can certainly increase sexual violence. And that's something that ACOG stresses as well. So speaking of disparities, aside from the disparities in terms of gender, there are disparities in how climate change affects people through their lifespan. And if we think about kids and infants, they have a greater area to mass ratio, leading them to be more vulnerable to heat-related illness. They also have an increased ventilation rate and hand-to-mouth behaviors, and that puts them at increased risk for having things like diarrheal disease and more exposure to environmental pollutants. We're going to focus more on the obstetric outcomes. So we're going to focus more on the obstetric outcomes, but I do have to mention, because we're going to talk about air pollution in particular, that air pollution is said to contribute to anywhere from 100,000 to 200,000 excess deaths in the US per year. And I think that kind of bears repeating, because we're so rightfully horrified of the amount of people that we've lost to COVID. But when we think about it in that context, this is repeatedly happening every single year when there's stuff that can be done to prevent it. So air pollution is comprised of a lot of different chemicals, but the ones that have the most adverse effects on health are ozone and what we call PM 2.5. And that PM 2.5 stands for particulate matter that is less than 2.5 microns. And so they're not the smallest, but the smaller that can reach further into our respiratory tract, like into the alveoli. So that's why it seems that those particulate matter sizes are of most concern. So adverse outcomes that have been related to air pollution include preterm birth, low birth weight, stillbirth. And, you know, we already knew that particulate matter could be related to poor pregnancy outcomes because we saw it since at least 2009 in studies that showed that exposure to carbon monoxide and particulate matter through smoking led to IUGR and low birth weight. And this is something that we counsel patients about all the time. So kind of switching over to extreme heat. Adverse outcomes that have been related to extreme heat in pregnancy include abruption, preterm birth weight, low birth weight, similarly stillbirth, and of course, as I mentioned before, an increased risk for heat exhaustion and stroke in the pregnant person due to their compromised ability to thermoregulate. So there are two large systematic reviews that explore heat exposure and maternal health. This systematic review, like I mentioned, this one's global. Most of the studies were related to heat and preterm birth. And we saw that 15 out of the 17 studies did find a correlation between heat and preterm birth. I thought it was important that the author proposed a couple of take-home points, and that would be that one, the timing matters. So earlier in the season, is worse because there's less of that acclimatization. And also the importance of urban planning because increasing green canopy will both decrease particulate matter and also temperature. The second large, and I mean large, systematic review, this one is US based from 2007 to 2019. And it included more than 32 million births and 68 studies. The adverse outcomes that were of interest were preterm birth, low birth weight, and stillbirth. And it found that 84% of the studies found a relationship between air pollution and adverse pregnancy outcomes, and 90% found a relationship between heat and adverse pregnancy outcomes. The stillbirth studies were, of course, fewer because this fortunately is an adverse effect that does not happen with a lot of frequency. And one of the key findings is that there was a 42% increased risk with third trimester heat exposure for stillbirth. So that's huge, 42%. Of course, the absolute risk is still low because it's a rare event, but 42% increased risk with third trimester heat. And unsurprisingly, we saw that there was increased risk for patients with asthma as well as minority groups, especially Black mothers. So why are we going to talk about the placenta? So we know that the placenta is the organ through which environmental and chemical exposures reach the fetus. And ACOG discusses this specifically in their committee opinion on toxic environmental agents. And they talk about how certain exposures accumulate in the fetus at an even higher rate than the mother. And an example of this is mercury, for example. Air particulate matter is yet another one of those exposures that crosses the placenta to reach the fetus. And of course, this being a PACE2 talk, I need to plug in the importance of doing an environmental health questionnaire. Personally, I try and add this to all my particularly first OB or preconceptual patients. And again, there are questionnaires that allow you to do this in a short amount of time. And the good news is that those questionnaires both identify exposures, but also suggest steps in order to mitigate those exposures as well. So yeah, I'm just a big believer that as providers of pregnancy care, we're responsible for helping those patients identify and decrease their exposure. So because I imagine that everybody here has a scientific streak, which means that they probably have a hard time believing something without understanding how it can happen. Bear with me for the next few mechanism slides. But, I think it is good to kind of have an idea that how we think that inhaled fine particulates affect preterm birth is by causing systemic inflammation and alterations in the autonomic nervous system. So there's still that, a lot that we don't know, but this is at least one potential mechanism. So as far as the relationship between air pollution and low birth weight, we think that happens from changes in the maternal cardiac and pulmonary function, that same systemic inflammation that causes that oxidation, changes in the blood viscosity, and altered placental gene expression. That basically what it does is it changes the genes that then will change the proteins that regulate fetal growth. And the problem with low birth weight is not just low birth weight in itself, but also the fact that unfortunately low birth weight can lead to increased risk for cardiovascular, metabolic, and neurodevelopmental poor outcomes later in life. In relation to air pollution and stillbirth, we see the changes in oxygen transport, DNA damage, placental injury. And in adults, so this is unrelated to OB, but in adults that are exposed to particulate matter, we see that it creates inflammation and can lead to an increase in the coagulation cascade, which of course makes sense that it could lead to stillbirth in that way. I want to highlight this Ohio study from 2015 that used air quality monitoring stations and found that at the highest levels of exposure to PM 2.5 in the third trimester, there was a 42% increased risk for stillbirth. And importantly, the study did adjust for age, race, and smoking. So switching over to extreme heat. So it's, pretty intuitive and makes sense to us that heat exposure will lead to reduced uterine blood flow, as well as potential changes in the placental fetal circulation, therefore potentially leading to that growth restriction. When it comes to prematurity, we think that dehydration will lead to prostaglandin release, oxytocin release, which we know can certainly lead to preterm birth. And an important study here was a retrospective study done in 2021 in Texas, where they found that preterm birth was increased by 15% after extremely hot days that were in the greater than the 99th percentile in the summer. Again, they noted the same relationship that extreme heat is worse earlier in the season and worse. The disparities are seen more in neighborhoods that have a higher economic disadvantage, unfortunately. As far as heat as it relates to stillbirth, the mechanism is similar. The lower amniotic fluid volume, which we can think can potentially lead to a cord accident, placental damage, and abruption as well. And there was stillbirth is something that is of course harder to study because of it happens less frequently. There was a California study that studied 8,000 intrauterine fetal demises and found a 10% increase in fetal demise for every 10 degree Fahrenheit increase in temperature exposure during pregnancy toward the later part of pregnancy. So one other adverse effect that I haven't mentioned yet, and that is the relationship between heat and anomalies. And in animals, we had already had evidence that heat could be teratogenic. I read about this unfortunate heat wave in Australia in 1963, where they started noticing that guinea pigs were having more miscarriages and were being born with limb contractures. And in humans, we have seen an increased risk in neural tube defects, gastroschisis, and anencephaly. All of those are more with first trimester exposures. And then typically these studies were done with exposures related to hot tubs, saunas, electric blankets, etc. There are a couple of studies that relate to ambient heat and anomalies. There's a 2013 Israel study that showed a slightly increased risk for multiple CHDs and atrial septal defects, as well as a 2019 multi-center US that showed that there was an increased risk for VSDs after longer exposures. And some effects, again, were seen only in the spring. In 2019, the Journal of the American Heart Association did a review of the literature on this and concluded that the burden of congenital heart disease in the US was likely to continue to increase secondary to climate change. And interestingly, they noted that that effect would likely be worse in the Midwest. So if you're like me, you don't like to hear about any problem that doesn't have a solution. So the good news is, there's a lot of great health benefits to climate action. And this study from California in 2018 showed that there was a 27% decrease in preterm birth before and after power plant closures, and that this was stronger in Black and Asian patients. I actually, at the SMFM conference last year, one of the speakers discussed the adverse pregnancy effects of climate change, and they talked about this specifically, saying that particularly now that we have such disappointing results with 17-hydroxyprogesterone, maybe it's time for those MFMs to go out and march for clean air rather than progesterone. So this comes from the 2019, the American Thoracic Society reviewed the literature and created a timeline that listed times when the benefits were noted after reduction measures. And I think one of my favorite ones here is the fact that in 1996 in Atlanta, the city created alternative transportation plan that included, more mass transit, and therefore that led to decreased traffic and ozone levels. And the Medicaid claims noted that there was a 42% decrease in claims for childhood asthma over those 17 days. So an incredibly short time frame. Of course, longer term, since the Clean Air Act from 1970, the health benefits of cleaner air, despite the fact that we're still seeing those 100 to 200,000 annual deaths in the US, have been valued at about $2 trillion from the 1970s to today. And that's largely in all the lives that it has actually spared. So I think the one thing that I'm going to say in this talk that I would qualify as just a personal opinion and not, research based, is that I just think as humans, we've accumulated way too much hubris, and we really see ourselves as separate from nature and above the laws of nature as opposed to just part of it. So I particularly appreciate the CDC infographic that that really stresses the interconnectedness of it all. And I think it drives home the point that whatever is good for the planet is good for us. And I think I can just think of so many examples of this. So something like active transport, of course, is going to increase improve air quality, but it's also going to increase bone density and improve our cardiovascular fitness. If we decrease animal products, that's going to decrease carbon emissions, but we're also going to derive the benefits of a plant-strong diet, et cetera, et cetera. So the good news is that there's lots that we can do. And I just think that as the trusted messengers that we are kind of obliged to use that automatic platform that we have, whether it's with colleagues, with patients, or in our personal lives, in our community. And of course, the benefit of personal choices that we make is pretty limited, but I think it can be very powerful when it amplifies that message and changes the behavior of others. And this reminds me of in our street, a few people started composting with this orange bucket from a company that is called Collective Resource. And so you saw one orange bucket pop up, and then the neighbor asked, "Oh, what is that?" And then the word spread until now that you can visually see all those orange buckets popping up, and we're kind of infecting each other positively. So this infographic is an example of what high impact versus moderate impact, what choices we can make to limit our carbon footprint. And of course, I want to acknowledge that that we know that choices are limited depending on what our actual situations are, and that it is a privilege to be able to choose some of these options that may be better for our health and for the planet, right? We know that health professionals can and do adopt some of these behaviors at higher rates than the general population. And there's many steps that we can take in our homes in order to electrify, whether that is by opting for a heat pump to heat your home, whether that's electrifying your stove and using induction, whether that's electric transportation. And of course, for me, one of the most interesting ones to discuss here is family planning, because I would never, as a professional, ever tell anybody to change their family planning plans for the benefit of the environment. So to be clear on that, but for those patients who do want to limit their family size, when we practice in an evidence-based way that increases the efficacy and the continuation of that birth control method, we are also affecting climate action. And examples of that can be, doing same day start of whatever contraceptive method you're doing, whether it's an IUD, whether it's the pill, offering post-placental LARC insertion, asking about contraceptive needs at every single visit, no matter what the reason is. So yeah, reproductive health is also a way of climate action. So, so at work, in addressing indoor and outdoor quality, right, as far as outdoor quality goes, and this is an issue everywhere, but even more so in Western states that have to contend with wildfires at this point. Of course, you want to make sure that you're advising patients to monitor the air quality index and to avoid being outside when it's red or greater, or orange for populations that are sensitive, like patients with respiratory or cardiovascular index. And that to wear an N95 if they have to be outside in those situations, which prior to COVID, one might have looked like pretty strange, but these days pretty normal. So you want to avoid exercising outside in high traffic areas and close the windows if the air quality is poor. And the picture that I have here is an example of a DIY indoor air purifier, which can be more of you can find this online, and it can be more helpful for patients also that can be in areas affected by wildfires. Other advice to improve indoor air quality includes, of course, limiting or not smoking or vaping, not to use hopefully gas stoves, ideally electric, but of course I know that that's still very early. Avoiding candles and unnecessary chemicals, as well as venting well if one is frying or broiling meat, opening the door or turning on the hood of the stove. So a big shout out to this great Pesu handout. I have to say I'm also pretty proud of myself for creating the QR code that you can use to access it. So if you scan that, it'll take you straight to that handout. It's very practical. Not all of it is patient facing, but there's a couple of pages of important climate change health advice that you can give out to patients. And to the right is a handout by the CDC that talks about how to beat the heat and heat safety in general. And then at the bottom is an example of a urine chart that patients can use to assess their hydration status. So if somebody has to work outside, again, we have to unfortunately acknowledge that they have limited options, but they want to make sure that they're seeking the shade, that they're taking breaks often, that they're decreasing the pace, hydrating, and you want to be asking in the summertime about AC access. So if somebody doesn't have an AC, do you have a plan? Can you go to a friend's house? Can you go to a cooling center? Can you go to the mall? And also being aware of the limits of fans, because fans don't work above 90 degrees Fahrenheit. So in those instances, it's best to recommend to either, immerse in water, shower, or bathe. So as I mentioned before, almost 10% of greenhouse gas emissions come from the healthcare industry. And one of the ways that we can work against that is by, you may be interested in reaching out to your sustainability coordinator in your organization. And that can be a good first step. I wanted to highlight the Choosing Wisely campaign by the American Board of Internal Medicine, and their main goal is not sustainability oriented. However, as we know, a lot of unnecessary tests have adverse health effects, whether that is a medical risk itself, whether that is cost, whether that's anxiety, days lost of work, but also they come with their own carbon footprint. So by choosing wisely the tests that we're going to order, and that can be pap smear frequency, that can be not using screening ultrasounds for women at average risk for ovarian cancer, et cetera, we're also limiting our footprint at work. So these are all examples of different organizations and trainings that really do a lot of the legwork for you. Some of these I have taken, some of them I'm in the process of taking, some of them I'm going to explore. And so they focus on training individuals, practitioners, in order to train their colleagues. The program that I mentioned here by Eco America actually even gives you the slides that you can use for the future. So as far as these are other organizations that focus on decreasing emissions specifically from the healthcare industry, if that's what interests you the most. And this example right here is from one of our nurses at Illinois Masonic, who created a mosaic from medication caps along with her unit in order to increase the awareness for in terms of medical waste. And I just want to leave you with the words of a woman that I really admire. You may have heard of her, Dr. Ariana Elizabeth Johnson. She's a marine biologist. I heard of her originally through her podcast, How to Save a Planet. And she also has a TED Talk called How to Find Joy in Climate Action, where she talks about the fact that what you should do should be at the intersection of what brings you joy, what are you good at, and what is the work that needs doing. Something that she does really well in the TED Talk is that she highlights the importance of implementation. So understanding, as she says in the TED Talk, that I am currently communicating with you. Not all of us can be communicators, and many of us can and should be doing the important work of the nitty gritty, which basically translating a plan into action. And that can look like helping your organization figure out what native plants they're going to plant in the front yard, or that can look like finding patient education handouts that educate patients on this and disseminating those, or that can look like helping your organization figure out the logistics for leaving single-use plastic speculums and going with a more sustainable metal option. And that's kind of a note to myself. And so whatever role you pick, I just personally, selfishly have found joy in climate action by creating a supportive community of like-minded people, but also, sorry, right time, turning some of the climate anxiety into fulfillment. That's it.
Thank you very much, Marie. I'm sorry about your cough. Really appreciate this talk. And I was actually kind of surprised at how dramatic some of those biostatistics were, showing really big difference between exposure and health outcome when you compare people exposed to unexposed, and also the dramatic difference in people who, in the outcomes, when you kind of took care of some of the emissions. Now, I hesitate to ask you a question because you're coughing. I hope you're okay. Okay. One of the questions I have, and please enter in the chat any questions that you might have, is you talked about heat exposure, and I'm wondering if you have a sense or any scenarios when reproductive patients or in their reproductive life would be exposed to the heat exposure. Like, what exactly do you mean by that? Do you mean only heat waves?
So it would be either first trimester exposure through saunas, hot tubs,
Okay.
or excess heat from the ambient temperature. So yeah, it can be outside of either mechanical or ambient.
Yeah. Yeah, no, I hadn't thought about that one. I think it's also, I'm going to re-emphasize what you said about acclimatization, because in occupational health, we see that too. And actually, one of our OcMed residents just presented a case of a fatality of a new worker on the job that was in a foundry exposed to really high temperatures. It was, I think, first 2 weeks on the job. And that is something that is seen frequently when there are heat fatalities or any adverse health outcomes due to heat in the occupational field, is that it's the beginning of the work. It's often people who have not acclimatized, and it really does take a good 2 to 3 weeks to become fully acclimated. And so now, with your talk, you can see that these, you talked about one where the effects were more in the spring. I think it's really, really
Yeah, over
interesting.
and over in multiple studies. Yep.
Yeah, yeah. Debbie, are there any questions that have come through the chat?
There haven't been any so far, so I'm still waiting.
And Gary, do you have anything to add? I know that both you and Marie have developed this talk together. Anything you want to add about comments on heat exposure or the particulate matter exposure?
Well, I appreciate not only did you talk about the adverse effects of pregnancy, maternal and fetal health, but also the impact on anomaly rate, which is something that I'm going to expand on. And it was really very informative and actually inspiring. It made me feel better about things, listening to your action plans, the opportunities for all of us, and especially our physician responsibilities to advocate and educate. I have a couple slides on advocating, educating myself.
Mm-hmm. No, that's great. I also wanted to mention, you talked about particulate matter. That was one of the two main health exposures that lead to the health outcomes that you mentioned. And you did show a slide that showed where all the sources were of different climate change elements. And I wanted to emphasize and remind people that particulate matter comes from burning fossil fuels. I mean, that's the main source, is burning any fossil fuels. And in my lectures, I say actually burning anything. You can burn virgin redwood forest, and it is going to create particulate matter that is going to be harmful to health, either to the respiratory system, which is the one that we think of first, but also really interesting that these very fine particles cross the barrier from the alveoli into the bloodstream and then lead to those mechanisms that you described through the placenta, leading to the adverse health outcomes. But this is fossil fuels and forest fires too. Okay, any other questions, Debbie or Mike? All right, Marie, thank you so much. We can go ahead and start the second half of our conference now, because we've got 3 different people, all of whom have slides, so I'm happy to have them any extra time. So let's go ahead and start with our, excuse me, with our second session. So I am going to go back to sharing. Let's see, sharing my slides with our agenda. And then there we go. I'm going to introduce our 3 panel members. So this panel is on environmental exposures, fetal anomalies, and abortion access. We've got 3 panel members, including attorney Eve Gartner, Dr. Gary Loy, and Dr. Allison Cowett. Our first panel members, well, first of all, let me describe how we're going to do this. Each panel member has 5 to 7 minutes of slides. So we'll go through those. And then I have a few questions for the panel members to discuss, and then we will open it up to Q&A. But again, you will enter your questions in the chat. So I'm going to introduce our first panel member. I'm really excited to have Eve here from far away, the beauty of the remote, the remote Zoom meetings. But Eve Gartner is the managing attorney for the Toxics Exposure and Health Program at Earth Justice, where she leads a team of professionals charged with designing legal advocacy to protect human health from toxic chemicals. She also serves as part of Project Tender, a collaboration with TENDR is the acronym. And it's a collaboration of scientists, health professionals, and children's health advocates working to develop policy approaches to address the link between environmental exposure and neurodevelopmental disorders. Prior to joining Earth Justice, Ms. Gardner spent more than 15 years leading reproductive rights litigation, including serving as the Deputy Director for Litigation at Planned Parenthood Federation of America, defending the right to choose abortion and access birth control in courts around the country. Welcome, Eve, and we're happy for you to start your presentation. I will move the slides.
Excellent.
For you. Yeah.
Thank you so much. And I'm so honored to be with you all today. So just quickly, many of you might not be familiar with my employer, Earth Justice. We're a not-for-profit public interest environmental law organization with 15 regional offices around the country, 190 attorneys, and a growing team of scientists and research and policy analysts who support our legal work. We use legal advocacy and the strength of our partnerships with over 500 other organizations around the country and internationally, many of which we represent in litigation. And we work to advance clean energy, combat climate change, preserve magnificent places and wildlife, and protect the health of communities and our children and fetuses. And as Susan indicated, I came to this work after nearly 20 years of doing litigation to expand and protect reproductive rights. And you can move to the next slide if you want, Susan. Thank you. And this is just the team that I work with now at Earth Justice doing this toxic exposure and health work. Our work is largely focused on holding regulatory agencies, largely the federal government, accountable for protecting people and the environment from toxic chemicals, many of which, as you've already heard and which we'll expand upon, have significant impacts on fertility and reproductive outcomes. And I just want to add sort of parenthetically that having spent many decades both protecting women's right to control their reproductive destiny and now trying to protect people from toxic exposures, that the ironies are just hit me every single day, that abortion is an incredibly safe procedure that's now illegal in wide swaths of our country, and chemicals are extremely toxic, many of them, and dangerous to human health, and are largely unregulated. And I've been devoting my life to trying to, kind of flip that narrative. So next slide, please. This work that I'm doing now to protect people from toxic exposures is critical because, in the words of Linda Birnbaum, who was the longtime head of the National Institute for Environmental Health Sciences, we live in a chemical soup. The chemicals are all around us. Next slide, please. And we've known for more than a decade that our children, our babies, are being born, in the words of the President's Cancer Panel, pre-polluted with industrial chemicals. And these chemicals are crossing the placenta from parent to fetus. And studies show that babies are now born with hundreds of industrial chemicals already in their bodies. Next slide, please. And as many of you already, I think, appreciate, prenatal exposure, pregnancy has long been recognized as a potentially critical window of vulnerability for exposure to a variety of chemicals. So these toxic exposures occur from many different environments and many different media. They occur in the home from consumer products like furniture, which has flame retardants in it, that has stain repellents on it, rugs also made with toxic ingredients often, especially the underpadding plus stain repellents added, cookware with PFAS or other nonstick coatings that are associated with serious health effects, personal care products, building materials, drinking water, including our food and food packaging, and especially fast food, where toxic substances can enter the food, not just from the packaging, but also during processing. Those are the kinds of exposures that everyone is exposed to. In addition, some people are exposed to toxic substances on the job, people that clean for a living, industrial workers, farm workers, construction workers, and many others. And depending on where people live, they may also be exposed to high levels of, as we just heard, of toxic air pollution, water pollution, especially if they recreate in polluted surface waters. And all of these exposures aggregate in our bodies. Certain kinds of pesticides we might be exposed. Farm workers might be exposed in the workplace. They might be exposed at home from pesticide drift, and then they might be exposed again in their drinking water or their food. So these chemicals aggregate in our bodies, and there's also a cumulative risk from multiple different chemicals that work on the same endpoint. Multiple different chemicals that present neurodevelopmental toxicity or cancer risks. So these aggregate and cumulative risks are also something that we need to be aware of. Next slide, please. So some of these prenatal chemical exposures are linked to structural anomalies.
Sorry.
Yeah, no, I'm sorry. I should have teed that up. I think if you just keep clicking. Oh, I'm sorry.
No, this happened when I filled it all in. You have some narrative that went missing. And all that was left was the references. Why?
Oh, I'm so sorry. Well, for now, I can just say that in that I can just talk it through, Susan. So I'm sorry if I did something funny. So the chemical exposures are linked to, some of them are linked to structural fetal anomalies. So the first one I wanted to highlight, and this is in the missing text, is that trichloroethylene, which is also referred to as TCE, is a commonly used solvent that's linked to fetal heart malformations. And those in the top two bullets are the citations, or two of many citations for that. So TCE is actually associated with multiple health effects. It's also a carcinogen, but the most sensitive endpoint, or the effect that occurs at the lowest level of TCE exposure, is these fetal heart malformations. In addition, and this is the other missing piece of this slide, many phthalates, and phthalates are a ubiquitous class of plasticizers. Phthalates are linked to abnormal development of the male reproductive tract, and those two bullets support that. So the phthalates, the research has linked phthalate exposure with reduced anogenital distance, which is a marker of reduced fetal testosterone production during the development of the male reproductive tract. And human studies have shown that this reduced AGD, or anogenital distance, is associated with other malformations of the male reproductive tract, such as hypospadias and poor semen quality in adult life. And many of you may have seen the statistics that we are in a crisis in this country of declining sperm counts. Sperm counts have declined by 40% over the last few decades. And many people see phthalates as one of the associations to look to there. And phthalate exposure is linked to male and when females are exposed also to female infertility. And these are ubiquitous chemicals used in plastics, almost impossible to avoid. Next slide, please. Yeah, and here too, I think there's some text missing that I'll just try to
Sorry
in.
about that.
No.
I decided, Eve, that this is actually better to just sit and listen to you and then refer to
Okay, good.
practice. We need to just listen and not read.
Yes. So in addition to these structural abnormalities, chemical exposures have also been linked to developmental neurotoxicity. So I had just mentioned that the prenatal, well, actually, let me come back to that one. So the prenatal exposure is linked to autism spectrum disorder, attention deficits, hyperactivity, intellectual disabilities, and learning disorders. And one of the key classes of chemicals that is linked with these neurodevelopmental disorders are organophosphate pesticides. This is a broad class of some of the most commonly used pesticides used on a wide variety of food crops, such as corn and apples. These pesticides, just as a side note, were developed in World War II as nerve gas agents by the Nazis. We now spray them on our crops, and we are all exposed to them. And this class of pesticides is linked at very low levels of exposure with poor cognitive, behavioral, and social development in children. In addition to this class of pesticides, organophosphate pesticides, there's also real concern about the link between organohalogen and organophosphate flame retardant chemicals and their links with neurodevelopmental toxicity and harm. Flame retardant chemicals are used in virtually all electronics, both in the internal part of the electronics where the circuitry is, but also in the electronic casings and the display sands, the kind of the outside of your TV and your laptops and your phones that we're touching all day long. And the flame retardants used in these plastic casings are not, they're in additive form. So they're coming out of the casings. We're touching them. We're putting our hands in our mouth. We're eating our lunch. And they're also attaching to house dust. Our kids are crawling on the floor, playing in the dust, putting their hands in their mouth and being exposed to these flame retardant chemicals. Next slide, please. I think it's also really important to underscore, I think it's the next one, that these chemical exposures are not equally felt. We know that people with lower incomes, people from communities of color, often have disproportionately high body burdens of these toxic chemicals we're talking about, like phthalates, flame retardants, and pesticides. And on the pesticides point, I think it's really important to know that farm workers are the most highly exposed, and farm worker communities we know are largely Latinx, and largely have very low incomes. In addition, the communities surrounding agricultural sites, rural communities, also largely low income, tend to have very high exposures to pesticides. But it's not just these farm worker communities and pesticides. We know, and these are the citations here. The first set of citations support the fact that Black and Latina women of reproductive age experience disproportionately high phthalate exposure, which has been documented now in multiple studies. We also know that the highest level of flame retardant chemicals are found in children from low wealth households and communities of color. And that's the bottom two. There should be two bullets at the bottom. There you go. And so next slide, please. I guess then the question is, what do we do about this? And I think that's, we can talk about that to some extent afterwards, and all of these bullets are gone. So that's leaves us.
I never saw these bullets.
I think my slides had a kind of gray background and white text, and that was probably a mistake because I think the
Oh.
gray background went away and all we're left with is white. So I apologize for that. I can share with you if a different version that could be shared with the folks in attendance. So what do we do about it? One thing that I think it's really important to know is, and for your patients and clients to know, is that we should not assume that because something is sold across the country in big box stores that it's safe. There's no, our federal regulatory schemes are broken, quite frankly. And there are unsafe levels of toxic chemicals in a variety of products that we buy. And years ago, we petitioned the Consumer Product Safety Commission to ban organohalogen flame retardant chemicals in consumer products. There were 2 public hearings, lots and lots of testimony. The Consumer Product Safety Commission agreed with us. They issued a warning document. They said that these chemicals are extremely toxic and especially of concern to pregnant women and to children. And they urged manufacturers to stop making them, retailers to stop selling them, and consumers to stop buying them. But they didn't take them off the market. They said they were going to study that. So that happened in 2017. And we see this time and again, OSHA, the Occupational Safety and Health Administration, who's responsible for safe workplaces, admits that it's what it calls its permissible exposure levels, the level of toxic substances in the air in workplaces. It admits that these exposure levels are outdated and underprotective. They haven't been updated since the early 1990s. The OSHA says that on its website. You can go to it and see that language, but it hasn't changed the level. So it's important for healthcare providers and for patients to know that when it comes to toxic exposure, the government is not yet protecting them. And so you shouldn't assume that because you can buy it at Target, it's safe. So what do we do? People of reproductive age should avoid chemical exposures to the extent they can before and during pregnancy. And the before period is important, right? It's not, if you wait until you know that you're pregnant, it may be you're already being exposed, and some of these chemicals are persistent in the body, so it's not just a matter of stopping, the day before you get pregnant, because they, especially the flame retardants and PFAS chemicals are quite persistent. So avoid chemical exposures to the extent possible, but we have to admit it's not always possible, and it's largely not going to be possible because these chemicals are so ubiquitous. I think it's important for healthcare providers to ask about environmental exposures as part of the patient history. Find out, are people exposed in the workplace? Is there anything that they could do to limit that? Perhaps amplifying the use of personal protective equipment during pregnancies. And we can talk later about more potential solutions, but understanding the potential exposures is the first step. And also, in addition to knowing more about the patient's environmental exposures specific to patients, it could be helpful to know more about the sources of toxic environmental exposures just in the geographic area where you're practicing. Are there military bases nearby? They're often a source of drinking water pollution and air pollution. Are there facilities nearby that are emitting toxic chemicals into the air so that there are particularly high levels of formaldehyde or other kinds of chemicals associated with certain kind of industrial processes? Just understanding that in the area where you practice, and then monitoring the patient for health effects associated with those chemicals is one important action, and we can discuss others later. So thank you very much.
Thank you so much. I want to make sure I'm unmuted. Thanks so much, Eve. I already have some questions in my mind, but I want to go immediately to, oh, that's beautiful. There, I want to enjoy that slide. Want to go right to Dr. Roy so we can see his slides and move on to Allison's and then have our discussion. So Just to introduce Dr. Loy, he is a maternal fetal medicine physician at University of Chicago and clinical professor of OBGYN at Carle, Illinois College of Medicine down Urbana-Champaign. He has expertise in the diagnosis and management of fetal growth restriction, the care of patients with preterm labor, and the management of pregnancies with fetal anomaly, which are key outcome measures in detection of fetal effects of environmental exposure related to air pollution, airborne particulates, and climate change. He's a member of our EPA CDC-funded Great Lakes Center for Reproductive and Children's Environmental Health, the sponsor of this event. With funding from educational grants, he developed a thread of environmental medicine subjects within the University of Illinois Urban Medicine Program curriculum while he was Associate Dean and Co-Director of that program. Welcome, Dr. Loy.
Thank you. And again, thanks for inviting me, and thanks to Marie and Eve for such a broad and interesting combination of aspects of environmental exposures. My focus will be on fetal anomaly and the what we face with abortion restriction, and I'll talk a bit about potential physician response. Next slide, please. And I don't have anything to disclose. Next slide, please. I believe that anomaly will increase without access to abortion. And so my focus will be on primary prevention of fetal anomaly. The reduction of the occurrence of fetal anomaly is not a new goal, it's a worldwide goal. And meeting this continues to require our recognition of risks and then the attempt to reduce that kind of exposure that causes anomaly. And in states that abortion will be allowed, it may be restricted, and we need to recognize risk of anomaly very early in pregnancy, and that will be critical to detection and giving some patients access to abortion if that's their choice. Next. I hope that after this, you'll be able to describe challenges in identification of teratogen exposure and challenges for referral for abortion of anomalies in our current climate. And we should advocate for the continuation of physician training opportunities so that abortion services remain available in patients who need them. And I hope you can then discuss the positive impact of processes, plans for early identification of anomaly and the effect on the referral for termination for fetal anomalies, the prenatal and pre-pregnancy opportunities that we may have for reduction of anomaly rate. Next slide. We have some responsibilities. I hope that we are advocates. I love seeing the word advocate and educate in the previous presentations. We need to advocate for early prenatal care in order to give patients opportunity to see the genetic component of their fetus, and then especially advocate for preconceptional and interpregnancy screening for environmental exposures, risks that can compromise fetal development, result in anomaly. We as maternal fetal medicine docs, and you should advocate that we apply early pregnancy ultrasound protocols to detect anomaly even before that 20-week scan. In previous presentations, it's been clear that disparities exist in adverse outcomes, adverse health outcomes, and some of these disparities disproportionately are created by disparities in exposure to environmental toxins, airborne, the particulates, heat stress due to climate change also. And these, I will emphasize, these exposures result not only in poor pregnancy outcomes and poor health for moms, but fetal anomaly. And in particular, the anomalies that show up are cardiac, facial, clefts, and neurodevelopment, all very serious abnormalities, most detectable. So we have opportunity here. We want to, as we've said before, reduce the impact of heat stress because this is going to get worse. Next slide, please. 65% of anomalies have cause unknown. 20-25% are chromosomal or genetic causes, and that leaves 10% that are environmental causes, both biologic and non-biologic. So the last part of the slide of the biologic causes, they really represent most of the occurrence of anomaly: diabetes, obesity, infection, Zika virus, which may rise again with climate change. Next slide. The non-biologic impacts have been discussed. The chemicals, the pesticides, other endocrine disruptors causing anomaly, heavy metal exposure, usually occupational, heat, we've mentioned again and again, air pollution, both physiologic effect and causes of anomaly. Therapeutic drugs can usually be avoided. Hopefully recreational drugs. Also, ionizing radiation is now fairly rare. Next slide, please. Just for perspective, the overall occurrence of a newborn with an anomaly detected within the first year is 4 to 5%. 3% are usually detected at birth or pre-birth. The overall percent of birth anomaly shows some disparity. In the US, we do have less anomalies born than throughout the world. Next slide, please. Anomalies can be divided into lethal ones. They have low occurrence, but a high detection rate. There are some disastrous, as listed here. Severe birth anomalies are detectable, and that's what we search for in our 20-week scan. They may be high risk for need for surgery or have major sequelae, major morbidity. Chromosome abnormalities, such as the common trisomies, do have a variable impact on health. But these abnormalities would then present opportunities for choice of continuing the pregnancy or not. Birth defects are important, even though we're drilling down to about 1% of the aspects of causing anomalies. Birth defects account for 20% of infant deaths, and that's increasing as we improve on reducing the causes of infant death outside of birth defects. Next slide, please. I'll read a quote by APHA executive director. Many communities lack access to nutritious, affordable food, or denied safe places to walk and exercise, or live near polluting factories. The health risks, and I'd say rate of anomalies, are greater for these families, and APHA is intent on reducing some of those risks. Next slide, please. I like this diagram because environmental exposure is all about place, and right at the top is residential segregation that's visited on the non-white populations, and then resident location defines what those environmental hazards and pollutants might be. That results in overall community stress, overall community exposure, but individual risk really depends. It depends on the combination of internal dose and your refractivity to that. And how you can respond to that. Stress levels in general reduce the defense mechanisms. And a health effect occurs, in our case, anomaly disparities then result from this top piece of residential location disparities. Next slide, please. So what results is these under-resourced populations, which are often confined to urban environments, do have reduced access to anomaly prevention and detection and opportunities to act on that abnormality. And then a number of things happen that eventually reduce the potential to access and prevent births with anomaly. The example, heat waves from climate change, or just heat in general in the environment, happens even without climate change. We know has happened in the past. And I think long-term urban planning, advocacy, and some possibly our participation should hopefully increase green space and make lives better. Next slide, please. So now I'll slow down a little bit and say that here are the barriers to successful abortion for potential adverse outcomes, the fetal anomalies. We still have a traditional problem of late recognition of pregnancy and late care. We have a general problem with access of care. that's disparate in our population. Some care protocols are not mandated, and I'd say that one of the MFM things that I am an advocate for is including an anomaly survey in our first trimester scans, rather than just looking dating at or one piece of the fetus that would potentially trigger a search for chromosome abnormality, which is the nuchal fold. And we have to think about this now, the threats that include current political climate, the restriction or elimination of abortion, and then oddly, this coincident opposition to a liberal birth control access opportunity, opposition to discuss sexual activity, or even to allow accessible reading material, particularly for our youth. So I believe the impact is the birth of children with anomaly will increase. I don't think we're going to be able to solve that problem entirely. And without access to abortion, my point here and one of my take-home messages has to be that it's primary prevention of the development of fetal anomaly that right now we need to make an impact on until the political aspects can be sorted out. And remember that prevention occurs, as Eva said, in the period before pregnancy or the interpregnancy period. Next slide, please. Simple things we and other physicians can do is to fix things we need to fix anyway. Blood sugar control, pre-pregnancy weight control, birth control access, sex education access, especially for teen pregnancies associated with gastroschisis, oddly, sexually transmitted disease prevention, sex education, again, syphilis continues to be on the rise, and anomalies and abnormalities are dependent on access and diagnosis and treatment, even interventions. And then, of course, identification of environmental exposures in our populations. And then implement risk, maybe exposure assessment, hopefully risk reduction. Next slide, please. So advocate, advocate, advocate. We can ourselves raise awareness in our non-OB world, internists, family practice practitioners, advanced practice professionals, and aim for these better health outcomes, better health care, prevention of preeclampsia with aspirin. You might say, why is that? Well, there is a there's an opinion that abortion may be accessible to patients who have life-threatening abnormalities considered emergent or life-threatening. How you define that might be different. But blood pressure and lack of blood pressure control and preeclampsia that results in patients with chronic hypertension may actually be one of those, even though they're rare, one of those aspects of life-threatening situations that might require termination, and still that termination may not be accessible. So that's why aspirin during pregnancy may be important. We should advocate for screening in early pregnancy, preconceptional screening, of course, questionnaires. I think outsourcing that to the waiting room or to non-physicians may be effective, and we can answer the questions. It can work out in the office. And then advocate to us MFMs for the implementation of this early examination of the fetus. Next slide, please. We need to educate and educate, encourage serum screening in the first trimester. That will help us identify chromosome abnormalities. And we need also to raise awareness of nutrient deficiencies, of course, folate deficiency and the impact on anencephaly, a neural tube defect is well known. But also there's potential to mitigate these environmental exposures, particularly environmental particulates and its inflammatory process with access to antioxidant food. So food deserts are a critical problem when it comes to this. So finally, to mitigate the adverse effects of abortion restriction, we do need to prepare for the inevitable loss of education and training opportunities for OBGYN physicians. There'll be less places for people to train in the performance of pregnancy termination throughout gestation, early gestation, and also the mid-trimester terminations that need to occur, and then prepare for increased utilization of the abortion access facilities like our academic institutions, and become aware of the precious staff that we have and the challenges that they will face. Next slide, please. And thank you for your attention. I already mentioned this.
All right. Thank
I
you.
couldn't resist.
Yeah. Thank you very much, Gary. That was fantastic. And I'm going to move on to Dr. Cowett, and then we will have time for our questions. So Dr. Allison Cowett is the medical director of Family Planning Associates in Chicago, Illinois, one of the largest independent abortion care facilities in the country. Dr. Cowett is an OBGYN and complex family planning specialist on the faculty at Northwestern University Feinberg School of Medicine, where she mentors physicians training to provide abortion care. As an advocate, she works alongside local, state, and national partners to safeguard access to comprehensive family planning services with a focus on people in marginalized communities, and to promote legislative agendas that champion reproductive freedom as a basic human right. Welcome, Dr. Cowett.
Thank you so much, Susan. Climate change and environmental exposure is not my usual area of speaking, but I was very excited when you asked me to be part of this panel. I'm going to try my best to put into context everything that the other speakers have talked about and sort of change course and talk just for a few minutes so we have time for questions about abortion access. And like I said, this is not my usual climate change and environmental exposure, not being my usual area. But frankly, I'm excited to speak in this group. It's been sort of extremely grueling lately since the fall of Roe and since the Dobbs decision to be siloed in the world of abortion care and abortion access. So it's nice to sort of think about things in a slightly different way. And just, it's certainly not lost on me that some things that Eve said in terms of as governmental agencies are not doing a great job regulating our exposure to these toxic chemicals, they are unfortunately doing a much better job regulating our ability to access abortion for our patients. So that is just perhaps part of the things that we're working to change. So I'll just talk really briefly about abortion for fetal anomalies in the US, the prevalence or approach to patients with fetal anomalies, and how Dobbs has changed what's happening in our clinic in particular and throughout the country. Next slide, please. So really important for people to understand and realize that when we are doing abortions for fetal anomalies, they are generally anomalies that are noted in the second trimester. And so they're a very small percentage of the abortions that are taking place throughout gestation. Hopefully it's a pretty common knowledge that the vast majority of abortions are taking place at less than 8 weeks gestation. And this is information we have from the Guttmacher Institute, which is perhaps our best collectors of data about abortion throughout the country. So as Gary mentioned, most of these structural anomalies are not found until the second trimester anatomy scan. And therefore, folks who are seeking termination of pregnancy in relation to fetal anomalies often come to us relatively late in pregnancy. And like Gary and lots of other MFMs, we have tried to advocate for these types of anatomy scans and sort of more detailed evaluation of the fetus on ultrasound earlier in gestation, especially as we see more bans throughout the country based on earlier gestational ages. Next slide, please. So just again, to put it into context, there are about between 54 and 63,000 US abortions occurring in the US at greater than 15 weeks of pregnancy. This is data from pre-Dobbs data, obviously, and there are lots of really smart people collecting data now on abortion prevalence and different gestational ages, now that people are having more difficulty accessing abortion earlier in gestation. But again, a smaller percentage of these will be for fetal anomalies, but certainly not an insignificant number. Next slide, please. So I wanted to say just a few words on our approach to patients with fetal anomalies that present to us for termination of pregnancy. This is the cover of a book that I like, written by a good friend of mine who just for interest's sake is called Rebirth, and helps people deal with pregnancy after this type of fetal loss or termination, but just for context. So first of all, there's certainly when patients are terminating a pregnancy for fetal anomaly, they, for better or for worse, often have more options for how they will end the pregnancy. Most abortions that take place in the second trimester in the United States take place via a surgical method or procedural method, dilation and evacuation. And those are primarily taking place in the outpatient setting. Much less common is induction of labor, induction termination in the mid-trimester. And the reason that's, and perhaps more commonly done for fetal anomalies, there aren't a lot of places that will do induction termination for patients that are terminating for anomalous fetus reasons. So that's why there are many more D&E or procedural abortions taking place. It's certainly important to remember that people who are seeking termination of pregnancy for an anomalous fetus and a otherwise very much desired pregnancy will have a grief process that can look a lot different than people who are terminating pregnancies because they do not want to be pregnant. And there's some interesting and pretty compelling literature that folks seeking abortion care for fetal anomalies will grieve in a similar way to women losing pregnancies through miscarriage, as opposed to people making a choice to end a pregnancy. And so certainly the care has to be individualized. Next slide, please. So to talk about Dobbs and the decrease in access to termination for fetal anomalies, this is a simple comparison between restrictive abortion legislation between the year 2000 and 2020, and certainly pre the SCOTUS decision in June, we did see throughout the last several decades a chipping away at the ability for folks to access abortion based on different restrictions throughout the country, and particularly in Illinois, since we see some of the most restrictive, even pre-Dobbs, legislation in Indiana. We are very used to, in our clinic in Chicago, taking care of people from other places in the Midwest where restrictions were severe. This is one of the main reasons why we have worked to advocate for the detection of fetal anomalies earlier in pregnancy, because a lot of these states, even pre-Dobbs, were passing gestational age limits. Say 20-week bans were becoming very common over the last couple of decades. And what that meant was that for a lot of people who had an anatomy scan at 20 weeks, and then were found to have an anomaly, a structural anomaly that for which they wanted to terminate, or then led to, genetic testing for then which they wanted to terminate. Those people were not eligible in many of these states, even though they would have been eligible for abortion care prior to 20 weeks in their own state. Next slide, please. So at the time of Dobbs' decision, this is just a sort of map that helps us understand where care is limited. And since this has been so much in the lay press, I'm sure people are really familiar with the fact that termination care or abortion care is really located on the coast or available on the coast and in very few places inland, Illinois being one of the major centers for abortion care throughout the country. And since we are surrounded so notably by restrictive states, we, especially in places like Chicago, have seen a huge influx of folks from out of state seeking abortion, obviously not just for fetal anomaly for all different reasons, but the people for fetal anomalies, particularly notably since they are, often traveling to Illinois in very tragic situations in terms of, it happens to me pretty much every week, if not several times a week, that I'm seeing women come to Chicago for abortion for an anomaly that is not compatible with life outside the uterus. So that's, particularly sort of frustrating and very difficult for people to have to travel so far away when they know for an abortion, when they know the pregnancy that they're carrying would not otherwise survive if they continued the pregnancy. Next slide, please. So if you're interested in this particular topic, the ever-changing what's legal where, this is a great resource. The New York Times keeps extremely well updated. So I guess I last updated this a week ago, but keeps very well updated, tracking states where abortion is now banned fully, or a 6-week ban is in effect. So you can see actually here, very important to us in our work in Chicago is what's happening in Indiana. And currently the abortion laws restricting all abortion is enjoined in Indiana. So it doesn't show up as a banned state on this New York Times map. However, it's when we're talking about fetal anomalies and environmental exposures, that is probably less important since it's extremely difficult to get an abortion in Indiana in the second trimester. Anyway, next slide, please. So real quickly, just going to finish with some very simple and I think interesting statistics about what's been going on in our clinic. You can see here, and we are one of the largest, if not the largest, independent provider of abortion in the country, and certainly a hub for second trimester abortion care in the Midwest and now for throughout the country. Over the last couple of years, you can see that the number of the number of out-of-state patients that we're seeing is significantly higher than it was before. And if we just compared our September numbers to our pre-COVID numbers, we're now seeing close to 3 times the number of abortion patients from out of state. Next slide, please. And then this is some of the most sort of remarkable data from our clinic, I feel, that in the wake of Dobbs, and this has sort of been consistent since June, when we look at what people are coming, who is seeking abortion here in Chicago, we've noted that the increase in is the most drastic in second trimester abortion. And again, that's related to the fact that people are having a harder time getting abortion in their own home state, given these 6 weeks bans, but also the fact that people are having to travel further, and this leads them to be later in gestation, and that we are seeing such a high number of patients with anomalies. These people that otherwise would have been able to get their abortion via induction of labor, even in the most conservative states, and in a lot of occasions have them paid for by their insurance, their medical insurance. Nowadays, we're seeing people from everywhere with these lethal anomalies. I took I did an abortion yesterday for a woman who was 20 weeks from Madison with multiple cardiac anomalies or multiple anomalies, structural anomalies, and oligohydramnios. So, and this, like I said, is happening on a very, very regular basis for folks with lethal anomalies as well. So just to put it all in context, our environmental exposures, unfortunately, getting worse. And I think Gary's right that we will see fewer people able to travel and obtain these types of abortions. And so more people struggling throughout pregnancy with these types of anomalies. Thanks.
Thank you so much, Allison, Dr. Cowett. And now I'm going to, let me put us into, I'm going to stop sharing and put us into gallery mode. That's great. I have a few prepared questions that I invite any of our panelists to respond to, but I will direct them at first. I'm going to start with you, Eve. This is something that I've noticed in my practice too, that from a policy perspective, the overwhelming majority of outreach to the public about environmental exposures exists of advice to avoid exposures. And how do you avoid? Don't microwave plastic, and don't avoid BPA, do this, don't do that. And that given that pregnant people are often already really concerned about the health of their baby and trying to do everything right, how do you recommend to temper this advice to avoid so as not to scare people or make them feel like they are solely responsible for their environmental exposures?
Yeah. Well, thanks for that question. It is a huge question, right? I mean, we don't want to add to the stress of people, because the stress itself, we know, can have adverse impacts on the pregnancy. And as we've talked about, by the time the person is pregnant, in some ways, the chemicals may already, be in the body, and there's nothing that they can do. So I do think, a few guideposts that are non-stressful, like, as you just said, Susan, avoid putting plastic in microwave is probably a simple thing, but it really is. I mean, we need to take seriously, this is a long-term problem, and it's really probably not a individual patient problem. And I think that actually it would be having more healthcare providers themselves advocate on behalf of their patients for the need to have stronger restrictions. And obviously, if patients also want to advocate for that, but they probably have their hands full. So, I wouldn't pressure them to do that. But I really think there's an important role for healthcare providers to press, and especially in light of Dobbs. I mean, I think that this is just staring us all in the face, that the government is making it impossible for people to control their reproductive destiny in many states. And they're also making it harder for people to have healthy pregnancies. And also harder to become pregnant when they want to become pregnant, because many of these chemicals are associated with infertility. And I think, doctors are, and not just doctors, the nurses and healthcare providers are really trusted voices, and they should be out there saying, you can't have it. You need, if this is where we are, you need to help people have healthy pregnancies. And so I think that's, we can't shop our way out of this problem. We can't spend our lives vacuuming house dust constantly. So I don't think that, we should be pressing, women and pregnant people to, sort of just try to do this, because, it really is it's a nationwide, it's a global problem. It goes beyond any individual. So I don't know if that's helpful, but
No, I appreciate that. Gary, I'm going to ask you a question about the patients that you have seen, since we specifically are focusing today on environmental exposures that lead to life-threatening fetal anomalies. When parents inevitably ask what caused the anomaly, do you mention potential occupational or environmental exposures, or does anyone ever ask? And if so, how has the Dobbs decision affected your ability to refer for termination for those patients who choose it? Sorry, those are 2 questions. 3
Well,
questions.
Everyone asks, every pregnant patient blames themselves for everything that happens in their pregnancy. So I'm careful not to mention any aspect of her experience or exposure at that moment. It's done. However, we do post termination or post-delivery counseling. There's a special clinic for that, actually, for pregnancy loss clinics, and that's not necessarily spontaneous loss. This is patients who've had terminations for anomalies and other reasons. So I do review all the categories of risk, and I never leave out exploration of environmental and in particular occupational and ongoing exposure causes or future causes. And of course, Dobbs is a disaster in terms of referral and I think impact on the healthcare providers. I mean, I don't know what's going to happen in Illinois. I'm not optimistic. Just thank you, Allison.
And turning to you, Allison, you're in the trenches, providing care in a safe state. We're making a connection today between environmental exposures that cause these fetal anomalies and how access to pregnancy termination services affects those scenarios. So can you reflect on how this lack of access to these services might affect the life trajectory of these pregnant people?
Yeah, so I want to answer your question, but I'll just echo something that Gary said. You know, certainly when people find out that they have, their pregnancy is complicated by a fetal anomaly and they're sent to us for termination, they also will ask us and, lots of different folks in healthcare settings, what did I do wrong? What could I have done differently? And the what did I do wrong, of course, is about really speaks to people want to know what to do differently the next time so that they can have a healthy pregnancy. And unfortunately, as Eve said, we cannot shop our way out of the environmental exposures. And sometimes anomalies will help us, figure out things that patients can do differently next time, but most of the time they don't. So I'm also very careful to, sort of help people understand that they're doing their very best and that they're, that this, whatever it is that there has befallen them in terms of a fetal anomaly is not related to their fault. That being said, how does this decrease in access really affect people? The thing I think is the most tragic about the decrease in access is how it really does, just like environmental exposures, disproportionately affect people that are in marginalized communities. So the same way that, folks are who are, in a situation, financially, educationally, all these different, all the different reasons that sort of make them more likely to be exposed to toxic chemicals also makes them less likely to be able to access great medical care, get an early first trimester prenatal care, get access to an ultrasound with a great provider, and then less likely, should they be diagnosed with an anomaly, less likely to be able to travel to outside their banned state to have an abortion. And what does that mean? It means that for those who would have sought out an abortion, they are sort of at every step of the line more likely to end up sort of being forced to have a child that then takes a lot of care and is special needs. So it's really, I mean, the fact that it impacts people at, again, every step of the way, harder to avoid, and then harder to manage, harder to treat once they have that anomaly is pretty tragic. There are lots of people to kind of end my comment on an up note, the abortion providers throughout the country and maternal fetal medicine specialists are working really hard to get people where they need to go. So, when folks have people with anomalies, we're in banned states, we're trying our very best to get them the care and the financial support that they need to come to see us in a more of a haven state. So, everyone's, as much as we shouldn't have to work against these ridiculous restrictions, some really wonderful people are putting their heads together to try and make it happen.
Thank you. Debbie, do you want to unmute yourself and let us know about questions to the chat?
Yes, we did have a few questions. Let's see. The first question was directed to Eve Gardner. So if you wanted to address that. The question is, in terms of harm reduction, are we better off focusing on better protections / more regulations of these toxic chemicals versus encouraging individuals we care for, i.e. pregnant people, to try to avoid these chemicals? Is avoidance even possible?
Well, I think the short answer is it's not possible to totally avoid chemicals. There's simply no way. They're in everything. And we need to eat, we need to drink water. So I think, there's might be some very simple things, but I'm hesitant to even really try to give that advice because it's, for example, some of this also cuts along these, lines of income and availability. It would be ideally everyone would eat organic food, but that's not economically possible for some people, and even apart from the economics, they might not be available in grocery stores that are accessible to many people. So I'm hesitant to, yes, some minimization would be possible if people could eat organic foods, if people could avoid eating fast foods or processed foods, if people could keep their house very clean of dust. But I don't know how, I think providers have to make the judgment of whether recommending that to their patients is going to cause kind of more stress and more angst and maybe not really doable. So I think in the bigger picture, the advocacy and the sort of, stronger regulation to protect everyone from these chemicals is the answer.
Okay, well, that question came from Allison. So does that about answer your question? Okay, great.
Could I say something? I think getting back to Marie's presentation on results she's had with community action, I think acting locally,
Yes.
acting locally, think globally, these are things that Marie's had success with, and it just demonstrates that we can make a difference at our level, and we probably, although I am discouraged, we probably shouldn't be discouraged by our outlook on how much of an impact we're making. But I think that taking those steps when we can and how we can is really critical, right? And now whoever's surrounding you.
Yeah, and maybe
in my department, I'll act to get that anomaly screen.
Yeah. And I think and just to add to that, my personal work has largely been focused on getting on federal work to try to get protections across the country, but especially, in states like Illinois, where there is a progressive legislature and a progressive governor. There are real opportunities to get protections in place, workplace protections, stronger drinking water standards, laws restricting even the sale of certain kinds of products. So that is eminently doable, and many states have done that at a statewide level, or even in municipalities. Chicago could adopt laws or restrictions. So absolutely, that is much more accessible than the federal changes at the federal level.
No, but even that's many more people than we can individually impact on. So thank you again to you for doing that. But we can still do something at our local level, no matter who we are.
Mm-hmm. Another question, Debbie?
Okay. I'm going to avoid reading names so I can not mess them up. So the next question is, if we have interactions, and this is for the panel, if we have interactions with low-income families that are in these environments and exposed to these harmful chemicals and pollutants, they often have no other choice. What can we do? What resources are available to help? Anyone?
Bree has plans.
Yeah, call the PASU. So this is one of the reasons that the EPA and ATSDR funded these centers for reproductive and children's environmental health. We're funded a teeny little bit, but there's a little pieces of FTEs of different people, including, mostly healthcare providers, but people like Debbie, who's now trained in how to do soil shops, going into communities and having people bring their soil to health fairs and testing the soil for lead. So we go into communities and work with them to figure out what their priorities are for their exposures, and then use our knowledge to look at what exposures might be already known from like a toxic releases inventory database from the EPA or something like that. And then work together to figure out what types of interventions are best for the community to safeguard their health. And a lot of times it's educating people about avoidance, once again, but, in the meantime, making sure people realize where the pollution is coming from, and letting their own activist groups, use that knowledge in the way that they find is the most efficacious. Does anyone else want to address that one? Debbie,
Well, one thing we can tell people, and I again refer back to Marie, is being able to try to control their indoor environment to the best of their ability. And then I do want to stress the potential impact of antioxidant foods if patients can get a hold of those. Unfortunately, some patients who we do run into in our practice, many of them have difficulty obtaining those, but I think with some effort and with an understanding the importance, I think getting to those colored vegetables and fresh fruits and all that is going to be potentially protective. I think we're going to find that inflammation is the mechanism of action of both later effects of particulates on pregnancies and also the rates of anomaly and the cell-to-cell communication that happens and is disturbed by whole body inflammatory processes. So I'd say that's one thing that we can do with populations, and that's something I do encourage early in pregnancy is diet.
great, thanks, Gary. Well, we've reached, my clock says 2:02. It might be a little fast, but we have reached the top of the hour. So I want to thank our speakers, our presenter, Dr. Marie Cabilla on climate change, and our panel, Attorney Eve Gartner and Doctors Allison Cowett and Gary Loy. I also want to thank Deviante Porter-Anduto for her excellent coordination of this event. I want to remind people, for those of you who do want the CME credits, please complete the evaluation form to get your credits. And if you're a resident and registered as a resident, we will be contacting you about your gift card incentives. Once again, thank you to everybody. Have a good afternoon.
Thank you so much.
Thanks.